Good afternoon, everyone. We're going to give us a couple more minutes, let a few more people log in before we get started. Thank you again for joining us. We will be getting started in just a minute. Great. Again, welcome everyone. I'm going to stop sharing real quick so I can see you all, so to speak. Welcome to our webinar on refractive lens exchange. I'm going to go through a few slides with you today, also give you some instructions and give you some idea of what refractive lens exchange is all about. First, I want to tell you a little bit about myself. I'm an ophthalmologist, refractive surgeon who has been practicing in the Lacey area for about 23 years. Been doing refractive surgery ever since I started, after having done a fellowship in refractive surgery at the University of Utah. We participated in several FDA studies, and I'll go through a few more things with you shortly about me, but let's get started and talk about refractive lens exchange. So I'm going to go ahead and share my slides. There we go. I think I got it here. Bingo. All right. So refractive lens exchange, everyone has heard these days about refractive lens exchange. RLE is all over the radio. I'm advertising, a lot of other people are advertising. And the main reason for that is refractive lens exchange has really evolved over the last 5 to 7 years. The technology is amazing. And really, we've got a great armamentarium to really help you see without glasses for both distance and near. Very exciting. So let's get started. Again, some of my credentials, I've been practicing, like I said, for 23 years, over 20,000 refractive procedures performed. I've also been a clinical investigator in many FDA studies. And most of those studies were based upon lens trials, basically intraocular lens trials. The multifocal lens that we use today was one of the trials that we were involved with early on. So I've seen the ones that have worked and the ones that haven't worked. So it helps us decide what the best options are for you, to see a lot of different options that are available. I did train at the Wills Eye Hospital, which is back in Philadelphia. It's one of the top 3 programs in all the country, and have also given back to many people in underprivileged areas of the world. For example, Bolivia, Haiti, and India, where I trained people how to do cornea transplants, actually. It was a fascinating experience. I was able to take my children with me. It was very, very rewarding experience. But I really couldn't do all this without my team. Okay, our team here at Aurora is amazing. They have a tremendous amount of knowledge, but most importantly, a tremendous amount of compassion. You'll see this in all our reviews. If you check out our reviews, the vast majority of the time they're commenting on the experience they had at Aurora Lasik with our team. Again, come on in to see us. Our team will give you the experience of a lifetime. And you can see our reviews speak for themselves. We have all 5-star reviews, and we pride ourselves on the fact that this is where we stand as 5-star reviews. Our most recent is Ian Furness. You may recognize him. You probably recognize his voice more because he's a radio host, and he's also advertising for us for this webinar. He just had RLE and is extremely happy with the technology. So again, check out our reviews. I think you'll be pleased. The first thing we want to talk about today is how the eyes work, because it's important to understand how the eye works before we can talk about how we fix it. So I'm going to give you a basic anatomy lesson and optics lesson on how the eyes work. Now, first of all, we have something called refractive error. And if you hear that, refractive error means nearsightedness, farsightedness, and astigmatism. And that gets you to focus the eye in the distance. We also have what's called accommodation. Accommodation is where the natural lens changes shape inside the eye to take that distance image and focus it up close. And then probably the most important, and the one we can't fix, is neuroprocessing or neuroadaptation. That is where the brain receives all those light images and then processes it and tells you what you're actually seeing. And this all happens in a millisecond. It's amazing. And the design and evolution of the visual system is continually fascinating me. But let's talk about refractive error and what those different things mean. Now, you may have heard of nearsightedness. Everybody's heard of nearsightedness. We call that myopia. Myopia is where you can see things up close without glasses, but you need your glasses or contact lenses to see in the distance. That is the vast majority of people. Actually, there's been a recent study out showing that they believe about 50% of the population is going to be nearsighted by the year 2050. It is what they're calling an epidemic. And it is something that we really are working on trying to help resolve with children, as well as once you get to a mature eye stage, that we're able to treat this with refractive surgery. Hyperopia is a little less common. That is where people need plus power in their glasses in order to focus images on their eye. And I'll demonstrate that in a little bit. Those patients can't see distance terribly well. They can't see near terribly well. So farsightedness is really not a great term. Then we also have astigmatism. I didn't put that on there. Astigmatism is also part of refractive error. And many people have heard they have astigmatism, but don't really understand what it is. And I'll go over that when I do my drawings. Presbyopia is what we're talking about today, is how we fix presbyopia. Presbyopia is the inability of that accommodative feature that I talked about, that inability of that natural lens to focus up close. So I'm going to draw for a little bit, so forgive my drawings here. I have a little eyeball back here on my wall, and this eyeball is in cross-section, and I'm going to show you what the eyeball is supposed to do. So if you have light coming in here, hope you can see these lines pretty well. The light's coming in, and in order for you to see the cornea here and the lens, this area here, have to focus the light back on the retina. So it needs to focus right there, okay? This area here is where we want the image to focus. When you're nearsighted, those same lines, because the cornea is steeper or stronger, it actually focuses it here, or in front of the retina. And so in order to correct that, what we do is we either with LASIK or with lens replacement, we can reduce the power of the cornea and or the lens to move that image back on the retina. So that's nearsightedness and how we correct nearsightedness. Farsightedness, unfortunately, I don't have a black pen. Farsightedness is exactly the opposite. These are too weak. And so the light, instead of focusing here, it focuses bigger. Can't see that very well. It focuses back here. So we actually need to make these things stronger. That's pretty tough to do with LASIK, although we can. And so a lot of times with farsighted patients, we will lean towards replacing this natural lens in order to increase the power of that lens. So that is a basic description of refractive error. Astigmatism, that's right, I said I would describe that here. Astigmatism is where this curvature, instead of being perfectly round, like a basketball, your eyeball is shaped more like a football, where there's a steep curve and a shallow curve. And what that does, that gives you two focal points. It gives you maybe one focus here and then one focus here. And so we have to bring those images together so you don't get double vision or blur. So astigmatism is a real nuisance. Now, again, I wanted to comment, I forgot to mention at the beginning, that if you have any questions or comments during this, please go ahead and use the chat or the Q&A section of the Zoom meeting. And we will try and answer those as best we can during the show, but probably address them at the end. So what is the problem that we're trying to face with refractive, or trying to fix with refractive lens exchange? It's presbyopia, or that inability to move that focal point up close so you can see. So a lot of people don't really have, well, people don't have presbyopia until they're 40, 45 years of age, where your arms start getting a little too short for you to read things up close. So what we tend to find, we tend to hear is, I don't see like I used to. My eyes are not working like they used to. I rely on my glasses all the time. I've never needed glasses. Seems like it just fell off a cliff one morning that I started needing glasses. And then, of course, many people have about 10 or 15 different pair of reading glasses scattered around the house, and they can never seem to find them when they need them. The cause of this, the cause of presbyopia, is what we call a dysfunctional lens syndrome. Your natural lens, when you're born, is able to move and focus quite a bit. So you're able to focus up close very well. But over time, that lens becomes less and less functional, hence a dysfunctional lens syndrome. And we have three phases or three stages of dysfunctional lens. DLS stage 1 is where the lens loses its elasticity and can't focus up close. That's where you start needing reading glasses. Or if you are somebody who's nearsighted or farsighted, you need to add a bifocal to your prescription. DLS stage 2 is where the lens starts to become very cloudy as well. So not only are you not able to bring things up close for focus, the images are starting to have more of a indistinct edge to them, or things are maybe at nighttime, you're having a little bit more trouble driving. This is DLS stage 2. Now, DLS stage 3 is where the natural lens becomes cloudy. Now, this is a picture of a pretty significant lens, pretty significant cataract. And that is when insurance considers this necessary to remove. So what we want to do is we want to address DLS stage 1 and 2 before it gets to this stage in stage 3. Now, there's a timeline of this. This doesn't happen overnight, although it seems like you just all of a sudden need reading glasses. DLS stage 1 usually starts in the early to mid 40s. And then DLS stage 3, usually probably 60, 65. So we're probably talking 25, maybe even 30 years sometimes, that you have to deal with this lens that is not functional for you until it becomes visually significant enough for insurance to consider it a cataract. So what we want to do is we want to solve this problem and not have you live with that 25 to 30 years of challenge by doing refractive lens exchange, replacing that dysfunctional lens while it is not useful. The procedure itself only takes about 10 minutes. It's done under topical anesthesia, so just drops to numb the eye. I then notice that you'll be able to have a pretty rapid recovery, meaning that next day, you should be able to get back to your normal function. I do the procedure one eye at a time. I mean, I do that. I'm conservative, so I want to do it one at a time so I can, because there are some very, very minor risks. I want to make sure that first eye heals perfectly. We do get some sedation. People are nervous, so we give you a little Valium, a little relaxation for the medicine. And then we also use topical anesthesia to numb the eye. It's amazing. Most people after their first eye say, you know, I'm surprised. I don't know what I was so worried about. It is surgery. It's your eyeball, so everybody's a little nervous at first. We do remove the natural lens with an ultrasound and replace it with an artificial lens. And like I said, quick recovery. That next day, you're functioning pretty well. Now, I like to utilize here, I'm going to stop sharing my screen real quick. So I like to describe the natural lens like a little M&M sitting inside your eye. It's about the size of a regular M&M. And it's got a shell on it. That shell is clear. And it's got a little yellow chocolate in it, let's say. Okay, and so over time, that chocolate gets more and more dense. That's that cloudiness, that DLS stage 2 I was describing. So what I do is I will peel the top of the M&M shell off, exposing the chocolate. I'll then remove the chocolate from inside that lens capsule, and then slide the lens implant back in that same capsule that held the natural lens in place. I get a lot of questions about if this lens will, how the lens stays in position, and that's how it does. It basically is held in position by the same way your natural lens was held. Hope that made sense. Let's get my slideshow clicking. There we go. And again, the results are pretty darn good. The next day, most people are back to normal vision, 20/30 or better the next day. and able to resume normal activities. Now, I don't want you going to jump on a trampoline with your kids or kickbox or anything like that, but normal activities should be just fine. And seeing a computer, you might struggle a little bit that day, but really pretty darn functional vision. By the time we see you after that second eye, and after that second eye is done, you're back to functioning that, I do surgery on Wednesdays, back to functioning by Thursday or Friday very well. Now, there are some risks. I would be remiss to not talk about it, the risks. The risks are very few and far between. The risk of infection, about 1 in 5,000. There's a risk of swelling of your retina and your cornea. Again, those are pretty uncommon as well. And I wouldn't say it's a risk, but a side effect of the lens. There are some halos at nighttime, and those halos gradually diminish over time to where we typically don't have much difficulty with those after the first 3 months. Now, about 5 to 10% of the time, these lenses, well, not the lenses, but the results of the lenses, I need to do a little tweaking, let's say, or a little adjustment of the lens power. And that adjustment of lens power is done with either LASIK or PRK in order to refine the calculations that we did to choose the lens power. The lens calculations we do are based upon measurements we take of your eye. And I always like to tell people that we are taking out a natural lens that has power and putting in a new lens with a different power. The problem is we don't know what the power of that first lens was. So our job is to use these calculations in order to figure out the correct power to replace the natural lens's power, plus correct your refractive error that's needed. The good news is we're pretty darn good at that. And about 90-95% of the time, we're able to do that with just our calculations. But occasionally we need to do some adjustments. And the reason we can do that, we've got a lot of amazing technology. We use a femtosecond laser to help us perform basically opening of that M&M shell, also correcting some astigmatism. And this gives us much more precision in our technique in order to help get a more reproducible result. Now, I'm going to talk to you a little bit about the different lens options that we have. Okay, we use 3 different lens options for refractive lens exchange. The first option is a PanOptix trifocal IOL, and IOL means intraocular lens. That PanOptix lens is very good for distance intermediate and near. The Vivity extended depth of focus gives us a little bit more distance in intermediate range. And the light adjustable lens is one I'll talk about in just a minute. That's the newest technology and pretty exciting. The PanOptix lens is the lens we use the most in our refractive lens exchange. It is a multifocal lens. I'm going to actually show you. Let me stop sharing my screen real quick. I'm going to see if you can see this lens. Try and do it so it doesn't get reflection off the light. Obviously not to scale, but this is a lens that has these rings in it that allow you to focus distance, intermediate, and near. Amazing lens. I used to use this lens in both eyes, but now we tend to combine this with our other lens, the Vivity lens. And that is because the Vivity lens, let me stop sharing again. The Vivity lens here has fewer rings and causes fewer halos. So the combination of the 2 lenses together give us an amazing range of vision, as well as a very low risk profile for the halos. And this is the Vivity lens, extended depth of focus. Again, lower risk of halos. If we use this lens in both eyes, we probably need a little bit more help with reading because it doesn't quite get the sharpness of up close. But again, combined with the PanOptix lens, we have found amazing vision with these lenses. Now, the light adjustable lens, RxSight is the company. The light adjustable lens is the technology that's been out for a couple of years now. And it is incredible for people who've had LASIK in the past, or radial keratotomy, or people who've had corneal surgery in the past, because we are able to put the lens inside your eye, that power I was talking about. And instead of doing LASIK or PRK afterwards, we're able to actually adjust the power of the lens implant itself while it's inside the eye. Pretty cool technology. We've been waiting for this for years and works very, very well for those patients with, am I not sharing? Am I sharing? I am good. sometimes my technology. That light adjustable lens is a wonderful technology. It is something that we do blended vision with, meaning I do one eye seeing distance and one eye seeing a little bit up close. It has a little bit of extended depth of focus as well with that lens technology. And so overall, a very good choice. However, it does have a relatively long postoperative course. We do those adjustments of that lens, the lens power, over it's going to be a 2 to 3 month period. So again, it's something that if you want the sharpest vision out there, it's probably our best chance with light adjustable lens. So I have some frequently asked questions that often pop up at our evaluations. And so I'm going to try and address some of the ones that you might be having right now. First of all, how do I know if I'm a good candidate? And really the only way to know if you're a good candidate is to come in. Come in and see us. We can take a look at the health of your eyes, look at whether your eyes are dry, whether there's any medical diseases going on inside the eye, and determine if you're a good candidate. And how do I know which lens to choose? And again, that's from coming in, talking to us, telling us about your goals. What are your goals of having refractive lens exchange? What are your activities? Are you an accountant who really needs to see things really tiny up close? Are you someone who would care more for the distance vision, or would you care for computer vision? We can kind of tailor the lens options to your needs. How long does it last? This lens should last you as long as you need it. The technology is something we can actually put in children. We don't often put it in children, but it can. The lenses are a material, an acrylic material, and then the light adjustable is a silicone that does last for years. Will I have the lens changed? A lot of people say, hey, I get my glasses changed often. Am I going to have to change the lens that's inside my eye as well? And no, we don't see that happen. The main reason why your prescription changes in your earlier years is your natural lens changes. Also, the eye is maturing. By the time you're in your 40s to 50s, your eye is matured, and the only changes that are occurring in your prescription are typically due to the natural lens changing. So we're removing that, putting in an artificial lens, which should last you. Now, why doesn't insurance cover this? Well, insurance doesn't consider getting out of glasses necessary. So they'd be happier paying for a pair of glasses than helping you with your lens replacement. To me, I think they should rethink that option, because I think they would save themselves quite a bit. As you know, glasses can get incredibly expensive. So should I wait? A lot of people are 55, 60, and should I wait for lens to do this until I have cataracts? I say that's an option for you, yes. That will reduce the cost by roughly a half, because you will still need to upgrade to the lens options that we use routinely here. But it is something that is an option for you. But why wait? Why give that 20 years of not being able to see? To me, I think it's an excellent option to do when you're 45, 50 years of age. Sometimes even we've had a few patients in their 30s, believe it or not, with refractive lens exchange. If they have the right prescription, that is something we can certainly consider, although we take that a little more cautiously as well with the young age. And how much does it cost? Of course, everybody's concerned about how much it costs. And it is $6,750 per eye, but this is all inclusive, and it is for a lifetime of vision. If we do the light adjustable lens, it is a little extra because of the time commitment that's there for both of us. But it is something that this is an incredible investment for your vision for a lifetime. So I think it's an amazing option. And give us a call if you are interested in a complimentary consultation. It is typically a $100 consultation fee, but for all our webinar guests, we're going to allow you to skip that fee. And we do an amazing amount of measurements and eye exams, one of the most thorough eye exams you're going to have, and to make sure if you're a candidate or not. Okay. So I hope I answered a lot of your questions on refractive lens exchange. This has been kind of a quick run through. Of course, we'll go through more when we see you here in the office. But if you have any questions, please throw those in the chat. Also, we can schedule you through our chat function here as well if you're interested. But Nicole here has been looking at some of the questions. I don't know if I can see my chat. There we go. Perfect question answers. How long do I have to be off work? That's an excellent question. Typically, we do these one eye at a time, separated by a week. The day of surgery, you'll be off work, and then we do need to see you the next day to make sure that that eye is doing well. Typically it is. And most people can return to work that day. The time in between the two eyes for me is the most challenging for patients because one eye's corrected, one eye's not. You can wear your contact in the other eye. But once you get that second eye done, you're really up and running that next day. So I do them on Wednesdays. Thursday, you could go back to work. It's a pretty quick recovery. You're just going to be using drops for a few weeks. But we do those 3 or 4 times a day for a week. And so you can use those at home, maybe once at work. All right. One answered. Perfect. Good. Well, again, thank you all for joining me. We are very excited here at Aurora Lasik to be offering refractive lens exchange. The technology, again, has evolved so much. The PanOptix Vivity combination has really done wonders for our patients and allowed us to get people free of glasses for both distance and near with minimal side effect. Thanks again. Oh, I have another one. Sure, I can answer a question live. Let's see. Where are my question and answers? Okay. So what if I have the astigmatism in my left eye? I'm sorry, I missed that, Therese. We can treat astigmatism with refractive lens exchange, and we can do that a couple different ways. I mentioned the femtosecond laser does some of our smaller levels of astigmatism correction on your cornea at the time of surgery. We also have lens implants that have astigmatism correction built into them, similar to the way your glasses would have astigmatism built into them. And that can be corrected up to 4 diopters of astigmatism with the typical lenses. And that's a lot more than most people have. Now, if you have more than 4 diopters of astigmatism, we have other ways to tackle that as well, but that would be special cases. I think in general, we correct it with the femtosecond laser or with the lens itself, and we can do that in either eye. So if you have astigmatism in one, we just use the correction there, and we don't correct it in the other eye if it's not needed. What's astigmatism? Yes, and the recording definitely will be available. To record again, you can go on our website. I have one from a few months ago that's on there already, but this one will be as well. We also had a question about makeup, and this is a very common question, how soon you can return with makeup, to wear makeup. And typically, I would say if we do it on Wednesday, by the weekend, you should be okay to wear makeup. We just don't want you rubbing the eye very hard after having the surgery. So in fact, we don't want you rubbing the eye at all, period. But removing makeup, you have to rub the eye a little bit. And so I would say probably by that weekend, you should be okay. Good. And I think I've got them all. Perfect. Well, if there are no further questions, please actually throw them in if you've got some more. We've got some time, so I'm happy to answer some more, but also happy to see you in the office as well for that complimentary examination consultation to see if you're an excellent candidate for refractive lens exchange. Great. When can I work out after? All right. When can I work out after? And what if I have 2 different prescriptions? So working out, I usually say that same time frame for makeup. So usually by the weekend, you should be okay. Sometimes if you have an astigmatism lens implant, I might say to hold off on the strenuous workout. I just want to make sure that astigmatism orientation stays in position. And then if you have 2 different prescriptions, that's okay. We measure both eyes, and actually we treat each eye individually in their correction. So we will be able to address the different prescriptions. And a lot of people are worried about the prescription that we take in the office as far as the lens power calculation. But with refractive lens exchange, your prescription, while it gives us an idea of what the power of the lens should be, the power of the lens that we choose is all based on our calculations. So everybody's worried about whether they said the right one, or is it better one or better two, better one or better two. That actually doesn't matter during our evaluation for refractive lens exchange. So you can not worry about your refraction. Okay, my left eye, perfect. Great. Well, again, I think that is all the questions. Again, thank you so much for coming in and evaluating or Thank you for watching us. I hope you can come in and get evaluated to see if you're a candidate for refractive lens exchange. Come meet our amazing team. Again, I think you'll see why we're getting 5-star results.